Good morning, class. Today we're going to go over Chapter 19, dealing with the face and related structures. We're going to go with the same basic outline that we normally do as far as going over anatomy, functional anatomy, evaluation, prevention, and then rehab. In all honesty, I don't think there's a ton of rehab that we're going to go into as it's all very individual. But we will go over how to handle emergency situations for the face and related structure injuries. Okay, good old anatomy, right? So, with this, it's going to be important to know the different bones of the skull. Okay, so we have the frontal bone, nasal bone. Nasal bone is probably one of the most commonly fractured bone in the face. It can be displaced or non-displaced, and there's been times where I've had displaced nasal fractures where it looks like it's sitting up underneath one of the orbits of the eye. So with that, we're worried about a deviated septum and other long-term issues that might arise with that. For the jaw, we've got the maxilla, which is the upper jaw, and the mandible, lower jaw. And it's important to note that for the upper jaw lining, it's important to note that the patient's superior row of teeth are held in place by the alveolar process. More of the cheekbone is going to be the zygomatic bone. Sphenoid is up a little bit more. What we're worried about, or when we're talking about the TMJ, temporomandibular joint, and we'll deal with that for people who have lockjaw, and that's stereotypically people who have either gone through orthodontics and braces or are used to chewing on things such as gum or Laffy Taffy, and they end up injuring and irritating that TMJ. Alright, and specifically for the TMJ, this is taking up a closer look. There's different articular tubercle eminence, glenoid fossa for that. And what we're worried about with the TMJ is malocclusion. So, with malocclusion, we're worried about opening and shutting of the jaw up and down, but malocclusion is where it doesn't line up properly, so it might be off to the side. Like that. Okay. So the malocclusion is a deviation of the normal alignment of the two opposable tissues, specifically the mandible and the maxilla. And then mastication is what we do in order to chew our food, to break it down, in order to swallow and get the nutrients that go into our stomach. The following indicates TMJ pathology, which is malocclusion of the teeth, and malocclusion is defined as deviation in the normal alignment of two opposite tissues, in this case specifically the mandible and the maxilla. When we're talking specifically about the TMJ joint, the articular disc found in the TMJ is actually concave on its superior surface and concave on its inferior surface. The disc is concave on both sides to allow for smooth articulation between the two convex bones that it lies in between. So that's something that you don't always see or deal with. Okay, moving on to the ear. Okay. So, the external ear, or the aurocolpina, is made up of cartilage, and that's usually what people get pierced. Usually the lower lobes is what they get pierced, but they can get the cartilage up top pierced and other different parts of it. The middle ear, what we're dealing with is, let me get my little arrow, middle ear is specifically the tympanic membrane, the three bones that make up the middle ear, which is the malleus, incus, and stapes. Okay, and these end up attaching to the inner ear, which specifically is looking at the semicircular canals enclosing duct. And then the facial and vestibular nerve goes through there. Okay. So I will tell you guys that one of the quiz questions specifically is on this ear, and the shape of the external ear is called the auricle, which is maintained by an accumulation of cartilaginous tissue. So it functions as a funnel collecting and focusing sound and helping guide it towards the nerves. Then the middle ear is connected to the nasal passages of a patient via the eustachian tube, as those help regulate the amount of pressure within the middle ear. It should be important to note that the cochlea and the semicircular canals sit within the bony fluid-filled labyrinth formed within the temporal bone. Okay, so when they ask, the answer will be temporal bone. And here's an up-close look. There we go. The inner ear, looking specifically at the cochlea. You might have heard of cochlear implants for those with hard of hearing. We've got the semicircular canals up here, and then the vestibulocochlear nerve, so cranial nerve 8 and 10, I believe. Okay. With the ears, you wouldn't think that we would have very many injuries with ears. What I have seen is those with concussion or post-concussion syndrome. They usually have a hard time with the cranial nerve 8 and their balance and hearing. They might have ringing in their ears, which is also called tinnitus. Then I've also had athletes, usually swimmers, that have either swimmer's ear, or I've had a couple ruptured eardrums just from usually with divers landing wrong, or once with a football athlete who had gotten just a lateral slap on his ear. So each of these can cause issues, and it's important to be at least somewhat familiar with that, and always, whenever you're in doubt, make sure you're referring them. Okay. Nasal or nose. So with this, it's going to be interesting to note, and this is actually a really good picture, when we're talking about airway adjuncts and we're using OPAs, oropharyngeal airway, or NPAs, nasopharyngeal airway. Those are measured by the tip of the ear to either the edge of the mouth or the tip of the nose. And with the OPAs, where it goes in through the mouth, it's a J-shaped device where when you're putting it in the person's mouth, you're going to run it on the top part of the hard palate, and then where you feel kind of like a little divot where it goes from hard palate to soft palate, you're going to flip the J in the opposite direction, so it'll fit just like that. And what that's doing is allowing a pathway for the air to go through. Usually, stereotypically, we would use an OPA first. The only time that I haven't, and not that I've had to do it very often, but the only time that I couldn't use an OPA was when I worked on an ambulance and it was a pregnant lady and her gag reflex was solid. So we ended up having to, talk to her, and we did an NPA through her nasal passage. The nasal septum is formed on its posterior half by the vomer bone and perpendicular plate of the ethmoid bone. Okay, so right up here. And then epitaxis. Do you guys remember what epitaxis means? Hopefully you're pulling back some of that memory from 108, and it's just the medical terminology word for bloody nose. So the artery that's typically associated with a patient bleeding anteriorly as a result of a nasal fracture is going to be the anterior ethmoid bone. The sphenopalatine artery is associated with posterior bleeding from a nasal fracture, but the anterior ethmoid is for posterior bleeding. Close that off. And working our way down to the throat. I'm sure I've already told you guys about my one crazy story where a football athlete somehow got hit in the throat and damaged the cartilage on that, and he ended up needing to be intubated and then was in ICU for several days. None of that's fun, obviously, and it is considered a medical emergency. And then as a result of that, since the cartilage was broken, he no longer could play or could wrestle after that. So with our throat, we've got the larynx, thyroid cartilage, coracoid cartilage, and the cornea. Cornea. Still early for me, guys. I apologize. So the structure that covers the larynx superiorly is going to be that thyroid cartilage. Okay. The structure that's located anteriorly in the neck that can be palpated and functions as the tongue's attachment site is going to be the hyoid bone. Okay. The hyoid bone is located between the mandible and the larynx. It's the only bone in the body that does not articulate with another bone. A lot of times the hyoid bone, when somebody hangs themselves or gets choked, it's the hyoid bone that often is fractured. Okay, moving right along to the, obviously, mouth. So where do I even want to start? Okay, so we have the tongue with the taste buds and all that fun stuff. When you lift up the tongue, so next time you guys are in front of a mirror, I want you to open your mouth, stick out your tongue, and lift your tongue up. And that little kind of flap is called the lingual frenulum. Okay. The small rough projections found on the surface of a patient's tongue that helps assist in movement of food during chewing is called papillae. The tongue is a skeletal muscle covered by mucous membrane and two structures, papillae and taste buds, is what comprises of the tongue. I've already gone over the lingual frenulum. That's the underside floor of the oral cavity, and I want you guys to go look at that when you're in front of a mirror. And then when we're looking in the mouth, everything that is past the teeth leading towards the trachea is going to be the oral cavity. And the mouth is divided into two areas, with the oral vestibule identified as the area from the lips to the teeth, and past that is the oral cavity. And then looking specifically at teeth. Okay, so for an adult, you have 32 teeth total for upper and lower, and the tooth breakdown is right here in a picture for you, where you've got excuse me, the root. You've probably heard of root canals, and that's usually when there's so much damage done to the enamel and possibly the dentin that they'll go in and do a root canal and kind of kill those nerves. So you've got the root, the neck, and at the neck is where you've got the gingiva sulcus, and when that's inflamed and irritated, it is called gingivitis. And then the crown is composed of enamel, dent, and dentin. So all these are important. Now, if and when somebody gets a tooth knocked out, if it's the whole entire tooth, root and all, I will rinse it with saline solution, not scrub it, because we don't want to damage anything that's going on at the root or the enamel. And then I will try and put it back in once. If it doesn't go in, make sure we put the tooth in some saline solution, or our bigger med kits at MJC have the Save-A-Tooth. and keep that with the patient and send them in. Ideally, if it's, during regular dental hours, you can send them to the dentist. If not, definitely the ER. Unfortunately, we've had a baseball player a couple years ago who took a line drive to the mouth and had 3 or 4 teeth knocked out. Ended up having to have multiple surgeries to end up rectifying that. He did go to the emergency room. They weren't used to doing more than one at a time. So it did cause, some issues, because if that tooth doesn't get in and doesn't get that blood flow back to the root, it definitely can end up dying and just turning brown and not being any. Okay, and this is what we're looking at. I've actually had one of my basketball players got elbowed in the mouth and one of his front 2 teeth cracked in half, where you can actually see the pulp, nerves, and blood vessels. And you can imagine anytime that hits the air, it's going to cause that patient extreme pain. The only thing I could have them do is make sure that air doesn't get in there, so make sure that their mouth is closed until they get to other medical help. When talking about teeth, we've got 4 incisors, and those are for our cutting. Our canines, or cuspids, there are 2, and that's more for tearing. Bicuspids and premolars is going to be for crushing and grinding, as are for the molars. Some of you may have had your wisdom teeth pulled out, and that's because, for whatever reason, if your mouth's not big enough, if there's not enough room for those teeth, whatever the case may be. But a lot of times in early adolescence, teen, early 20s, people have their wisdom teeth removed. Okay, now getting into a little bit more of the muscular anatomy, there are a ton of different muscles on the face, and it's true that it takes more muscles to frown, I think it's like 42 or 43, than it does to smile, which is like 4. So, little tidbit of truth right there. Opening mouth is going to be your digastric, mylohyoid, and medial and lateral petragoid, whereas closing is masseter, or you've heard of mastication, where we're chewing our food to kind of break it down. On table 20-2 in the text is going to be more giving more information on the muscles of expression, but I do want to touch base on Bell's palsy. Okay, what causes Bell's palsy? It could be a stroke, disease, or infection. It is identified by a lack of symmetrical movement or facial muscles when there's trauma or disease to one or more cranial nerve. So, a couple of different things. I actually had a tennis athlete when I was at Fresno who ended up with Bell's palsy. And how we could tell is when we were talking to him, and when he would smile, only one side of his face only one side of his face would have the muscles move, and the other side, it was just blank, or basically like paralyzed. My sister has had it right after she had her first child, and that was just a whole bunch of trauma and other things going on. But Bell's palsy is able to go away. There are some medications depending on what's going on. And then also there are, with the tennis athlete, we had to do rehab and basically kind of muscle re-education of some of the muscles of his face. Yeah. Okay, so when we're evaluating somebody who has a facial injury or related structures, we need to see kind of where it's at, and then go from there. So with everything, what happened, where does it hurt, what were you doing, so what was the mechanism of injury, what type of pain is it shooting, throbbing, numbness, radiating, whatever the case may be, and how was it caused? Was it a direct blow, or did it just automatically, start causing issues? Other signs and symptoms: vertigo, where it feels like the room is spinning, nauseous, vomiting, or congestion. So all of those can and do occur in the ear. The ear helps us with our equilibrium and balance, a little bit of proprioception also. When we're talking about the nose, was the bloody nose, did it occur because of a direct blow, or was it spontaneous? Maybe it's because of weather. When the weather changes and then the inside of the nares where it's really dry, it could lead to, spontaneous epistaxis. When we're talking about the ear, is it an ear infection? Is it ear infection? Is it swimmer's ear? Swimmer's ear is medically known as otis externa. So sometimes when that goes on, or the ear canals are angled, or when swimmers leave water in their ears, they run the risk of getting that. Involving the throat, same thing, what happened, where, how, all this other fun stuff. We also want to make sure that they can open and shut their mouth, also with the injuries to the mouth, and we're looking for any type of malocclusion. Okay, going back to inspection. So inspection of the ear. This one's pretty apparent. I've actually had a baseball athlete who was warming up a pitcher, and the ball took a bad bounce or something and ended up cutting the catcher's ear. So it looked like this, but 500 times worse. So with that, would require sutures. The tympanic membrane, if we have an otoscope, we want to make sure we're looking in there and seeing what's going on. Is it distended? Is there swelling going on there? Do they have battle sign? So the kind of bruising around the nose and eyes, or enlarged lymph nodes. And if we had lab, we would be talking about the different lymph nodes. Inspection of the nose. So this is a good picture almost of raccoon eyes or a little bit of battle sign. We want to make sure that the nose is in alignment. I would have them look in the mirror themselves, because they obviously look at themselves a lot more frequently than you do. If they are concerned, go ahead and have them go in and get an x-ray. Sometimes there's so much swelling that sets in, it looks like it's fractured, but it's not really. I would be worried about a deviated septum. So with that, I would have them close one nare, breathe in and out, and then close the other one, breathe in and out. And if there's any issues, make sure that we're sending them. Using an otoscope, we can use the otoscope to look into the nose and the ears, make sure we're changing the shields on that, and we're changing them between patients. Not like we use that a whole lot, but it's still a great tool to be able to utilize. Okay, when we're looking at the throat, asking about respiration. If they're having any type of difficulties, if it feels like it's itching or starting to close up, that's considered a medical emergency. They need to be able to breathe. So it's a good idea to have EMS en route. Looking at the thyroid and coracoid cartilage, if there's any deformity or pain when you're palpating that. Looking at the face and jaw, if there's any type of bleeding. When we're palpating, again, make sure we're palpating away from where the pain is and then start going towards it. Otherwise, they might just be not wanting you to touch them at all. Look at the muscle tone, ask them to say a sentence, or when you're talking to them, look at the symmetry of their face. Is it equal and bilateral, or is one side looking like it's lagging, almost like a stroke or Bell's palsy? Okay. Looking inside the oral cavity and looking at the teeth, make sure we're using our PPE. You can use a pen light or the light on your phone. Looking for any type of lacerations, any type of different movement or malalignment of the teeth. I feel horrible. I had a basketball kid one time where he'd gotten elbowed in the mouth, and he, like 3 months earlier, had just gotten his braces off, was in braces for forever, just got them off, took an elbow 3 or 4 months later and pushed 4 of his teeth in and ended up having to get braces again to try and fix that. Teeth, if there's any obvious or subtle fractures. I've had kids who, you know, they weren't even playing their sport and they were sucking on a sucker and chipped one of their teeth. So it can and does occur. If you are, you know, at a collegiate setting where maybe the kid's not at home and doesn't have their regular dentist, you're going to have to help provide or get care for that. Looking at the tongue, have them stick their tongue out, look under it, looking at that lingual frenulum. Gums, any type of inflammation or redness would indicate gingivitis, and that's something that I would tell them and have them follow up with their dentist. Okay. Palpating. So hopefully by now you guys know I palpate away from where it hurts and then go towards where it hurts. And I usually do bony and then go to soft tissue, because if I find anything pertinent with bony, I'm going to stop and send them out right then and there. Okay. So go through, match each of these points with the number. And then when we're palpating, make sure, again, we're using our PPE. On the right, they're palpating teeth. And again, you might have to wiggle to see if there's any looseness. Sometimes all it takes is a little push up further. And then on the left, what they're doing is they're having the palm of their hand face forward, and they're having their patient open and shut their mouth. So right now, I want you guys to stick your pinky finger in your ear with the palm out and open and shut your mouth. You're not doing it. Go ahead. Put your finger in your ear, open and shut your mouth, and you should be able to feel the backside of the TMJ. Okay. Palpating the lateral structures. So there's only 3 right here. See if any of those are causing them pain, or, you know, there's swelling there. Functional assessment, testing for the ear. Now, this isn't always easy, especially when we're on the field or in the gym. You may have to take them somewhere a little bit quieter. Or if they've just had an official blow a whistle in their ear, it's going to take a little bit for them to get their regular hearing back. But you can always do the Romberg test for balance and ask them if they're having any tinnitus or ringing in the ears. So right now, I want, on a piece of paper, I want you guys to write down Romberg test and just Google that and look that up. You'll see that police officers also use it when they're doing field sobriety tests. The Romberg test is one of the tests that we do when evaluating for a concussion. Okay. Selective tissue test for seeing what the TMJ, what their range of motion is. They don't have to fit knuckles in their mouth, but it's just a good indication and a telltale sign that you have them see how many knuckles they can fit in, and then you can note that, because it's not like their knuckles are getting bigger or smaller, because it might change or vary from clinician to clinician. Plus, I don't want to get my hands in anybody else's mouth. See, I didn't even need to do the face-to-face camera. I could have just waited for this picture. Observation for malocclusion of the teeth, where they open it and it's not lining up properly like it normally would. I don't know why that arrow is right there. Okay, neurological testing, loss of hearing and smell. I'll be the first one to admit it's the most difficult to assess is their sense of smell and that cranial nerve, because unless I have chapstick or something, maybe hand sanitizer in my pocket or on my bag, it's not like I carry something around for them to go sniffing. Facial pathologies and related special tests. So ear pathology, you're looking at that articular hematoma. There could be a tympanic membrane rupture, swimmer's ear, or it might have gone even further into the eustachian tubes and it increases pressure in the ear. If you guys have ever gone up to the mountains or been on a flight, and when you're increasing in altitude, how your ears will pop, that's kind of what they're dealing with there. I have all of these individual tables for you guys on the PowerPoint, so I would highly suggest that you guys go over and look at those. Nasal fractures, like I've said, it's the most common fracture of the face and skull. They might already have a pre-existing deformity. There's people that have broken their nose multiple times. Think of boxers or MMA. They're going to have the raccoon eyes. It's going to be tenderness to palpation. So sometimes when you got any of you who are in the 140 class, you have seen us write evals and put TTP, tenderness to palpation, or point tender. For that, we're looking for a deviated septum, septal hematoma, and this one is specifically talking about nasal fractures. Facial pathologies, so a throat injury. I've only had one of these, but it was pretty significant in my career. Excuse me. The main thing is we're worried about if they have respiratory distress. If they're unable to speak or there's a change in their voice, they might have damaged the voice box. Make sure we're not only looking externally, but have them open up and look inside the mouth too. More tables specifically on throat trauma. Facial pathologies, so mandibular fractures, zygoma fractures, maxillary, and Lefort. So this is just a picture. Actually, it's an x-ray, sorry. And hopefully what you're looking at is right there. So if the person is opening and shutting their mouth, is it malocclusion at the TMJ joint, or are we worried that they took a hard enough blow that they could have had any one of these fractures? Okay, so with that tongue blade test, so I've talked about tongue blades before when we're fitting helmets. Now we can also use them where we have them bite down, and not that we're playing tug-of-war, they're not a dog, but try and pull away. They should be able to hold that and not allow that to, go off. Okay, a couple different types of Lefort fractures. You can know that there are 3, 1, 2, and 3 right here. I'm not going to ask you any specific questions on this, but it's at least good for you to be able to know that there are 3 different types. Some more facial pathologies. So here we're looking specifically at dental conditions and tooth fractures. There's been times where when the whole entire tooth comes out and we try and replace it, that's fine. But if the tooth is fractured, make sure they're okay. They may have swallowed the piece. If not, have them spit it out, put it aside, and send them to the dentist or the ER. I had the patient that I was talking about before where he had a fracture of the tooth. It was over here, like the class 4, where you could actually go in and you could see that air pocket and the root. Whereas tooth luxations, so dislocations or subluxations, dislocation, it actually all the way comes out, and then the other ones, there's different types of luxations where it might be partially displaced, so it's just rotated. It could have been pushed down further, and I've had somebody who fell off monkey bars and their teeth were shoved up higher in their gum. Or it could have been a little bit extrusion where it barely comes out, but it's not where it needs to be. So you can see maybe the artery and the nerve roots are not disconnected. So if we don't get that down and we don't get blood flow to it, it runs the risk of the tooth dying and decaying. And then the complete avulsion, like I said, if it comes out root and all, go ahead and try once to put it back in the correct way. Okay, TMJ dysfunction, pain when opening and closing the mouth. They might have audible noises where they say that they can hear a creak Usually when there's been a dislocation of the TMJ, it's because of a lateral blow. The teeth are no longer aligned, and the jaw is no longer in alignment. Okay, so on the field, we're almost done, guys, bear with me. So on the field management of face and related injuries, first we want to control any type of bleeding. Stereotypically, it's the nose. Palpate, make sure there's no fractures. If there are any type of embedded objects, whether it's in the eye or anywhere, we do not want to remove it. That embedded object, whether, it's a pen or whatever the case may be, might be occluding an artery or whatever the case may be. And if you remove that object, now there's nothing holding that down or closed, and you run the risk of, starting to bleed out. So facial laceration, and anytime something is significant, we want to refer them, because that is the face. It's the first, only face they're going to have. But you also need to make sure that they understand that they need to be seen within 24 hours. If it's longer than that, then they can't do stitches, because it's not going to heal like it needs to. Throat laceration, it's immediate referral. On the field evaluation, again, we're going into laryngeal injuries, seeing if there's any type of crepitus or crunching in there. How are they in breathing? Do they have stridor, which when they're breathing, it's a high-pitched sound, kind of sounding like a blowing wind. So that would also be something for them to get looked at. Anytime that they have trouble breathing, we need to stabilize and transport. We're not putting ice on it unless, they can hold it on there. It's not like we're going to wrap ice on their neck. We're not going to be that athletic trainer, guys. Facial fractures. If the athlete is conscious, make sure we're talking to them about what's going on, and talking them through the process. Try and keep them calm, cool, collected. Same thing if mom's there, mom or dad, or, roommate. Try and give them a heads up of what's going on. We want to make sure that we maintain the airway and transport, so we're not running the risk of jeopardizing that airway. TMJ joint injuries, if there's malocclusion, we want to refer to a physician or a dentist. So with this, I wouldn't necessarily refer to just a GP. I would try and refer to an ear, nose, and throat doctor. That way, that's their specialty, and they can help better figure out what's going on. Nasal fracture and nosebleed, control the bleeding, squeeze it, tilt, make sure we're icing it. If need be, you can put either a nose plug or, believe it or not, tampons cut up work really well. You can also put a rolled gauze between the top lip and the gums to help kind of stop that. And we're going to ice. Dental injuries, if the tooth has come out, make sure you find the tooth. If you say, we're going to find it later, once you send the athlete or patient to the doctor, if they don't have it right then and there, they're just going to move on. So take a minute or two, try and find the tooth, and you're thinking, believe it or not, when teeth get knocked out, sometimes they get kicked or whatnot. I've had it happen in not only a baseball game where there was a hit at the plate, but also in basketball gym, and trying to find that tooth is not the easiest thing that one would think of. If there's a tooth fracture, if they're not loose, they can return to play with a mouthpiece, but they do need to follow up with a dentist. So, the tooth has come out. We only want to rinse with water. We don't want to scrub or damage it by any means. And we want to put it either in Save-A-Tooth or saline and send it with the patient. Don't attempt to clean, sterilize, or scrape the tooth. Don't hold it by the root. and can be immobilized with aluminum foil. Transport to the dentist as soon as possible. But it seems like it never fails that it always happens outside of normal business hours. So if you guys can, develop or cultivate a relationship in the city or town that you work in with local dentists and say, hey, is it okay if, we give you a call if we have an emergency? Okay, so that's trying to be prepared and think of things ahead of time instead of after the fact. Okay, that's all I have for face and related structures. It's only 40 minutes, so hopefully a little less painful than normal. This is the second and last video of this week. I will try and get the videos out earlier to you guys, and I will chat with you later.